All right, thank you, everybody. So what I'm going to do for the next 30 to 40 minutes is just talk a little bit about the work that we've done as the CHoSEN Collaborative. And again, as was just previously introduced, this is a collaborative of hospitals throughout the state of Colorado, but also Wyoming. We actually have two regional hospitals in Wyoming, both in Cheyenne and Casper, Wyoming, who've just recently joined the collaborative. So it really is growing into more of a regional hospital collaborative. And it was created in 2017. A group of us from the University of Colorado School of Medicine, it was a group of neonatologists, were interested in this work and started talking about how we can try to standardize the hospital care that we give our newborns who are exposed to substances. It focuses primarily on opiate exposure, but does incorporate other substances as well. And so what I wanted to do today, is two things. One, I want to talk a little bit about how our understanding and our approach to the care of substance-exposed newborns has changed within the healthcare system really over the last probably 5 to 10 years. And then I want to talk specifically about the work that we're doing here in Colorado. So first we'll talk about the old way. So the old way, for those of you guys who work in hospitals or in healthcare, the old way was essentially to focus, at least in the hospital setting, primarily on identifying the infants that were at risk for what we used to call neonatal abstinence syndrome, and then treating those babies. And the primary treatment was pharmacologic treatment. And so essentially you would have your it's an example of our newborn here who looks quite uncomfortable. It would not be uncommon for these babies to have increased tone, to be crying, to be fussy, and the main way we intervened was by providing pharmacologic therapy. This is the Finnegan scoring system, which was used for a number of years, is still used, I would say, in a number of hospitals throughout the country, which was a very complex and, as you can see, detailed scoring system to evaluate symptoms, and particularly focusing on symptom control or identification and control of the baby. And then this is the environment that most of the babies were cared for. This is just an example of a wide open neonatal intensive care unit. The majority of babies who were identified with substance exposure that required medical treatment were put in a neonatal intensive care unit. So you can see very impersonal. You can kind of get a sense that there's a couple of parents in the background kind of looking over their baby, but there really wasn't an emphasis for truly integrating parents into the care of these newborns. So then a couple of things changed. I'm going to go through just a couple of examples throughout the country of different work that was done. This started in the Northeast, in hospitals in Massachusetts, as well as Dartmouth. So this first paper is I think what really started some of this work was by Matthew Grossman, and this is essentially a comprehensive quality improvement initiative that was created a number of hospitals in the Northeast to look at specifically how do we improve the care of these babies. And I'm just going to go through, this is just an example of sort of their work over time. I apologize, I don't have a pointer, but if you look at, to start, essentially they started by standardizing what they called non-pharmacologic care. And one of the main things we realized is that rather than focusing on simply treating these babies pharmacologically, that we really had to focus on non-pharmacologic care, so the basic care of the newborn infant. So they began with that initiative. They then looked at changing transfer to the inpatient unit, so really altering the environment where these babies were cared for. Rather than being in the neonatal intensive care unit apart from their families, they were transferred to a inpatient pediatric ward, and a real emphasis on keeping the family, specifically the mother and the baby, together. And then they changed how they managed those infants and how they assessed for neonatal abstinence syndrome. And so I just showed you that long form with the Finnegan that had a number of different physiologic and features to take into account. They simplified this, and we'll talk about this later, into essentially looking at three main components of how the baby was able to function. So is the baby able to eat successfully? Is the baby able to sleep? And is the baby able to be consoled? And if they were to do those three things, then they would focus more on that rather on some of these other more arbitrary measures. And they would use that to dictate their pharmacologic interventions. And then they then focused on prenatal counseling and then finished by changing their medication algorithm. So I think it's interesting, a couple things we learned from this. One, you can see their improvement over time. This is length of stay over time, and then the same graph with percent of babies that were treated with morphine over time. And I think it's interesting when we looked at this to realize that a number of their interventions really didn't have anything to do with actually the medication, how they medicated these babies. So this was, I think, enlightening to us in the healthcare system, in particular in Colorado, and how we've sort of changed our mindset that, again, they began by looking at non-pharmacologic care. How do we care for these babies? How do we keep moms and babies together? And saw significant improvement, and then only at the end, looked at the pharmacologic therapies, which is completely opposite of what we were doing in the past. So this is another effort by Alicia Walkman. This is another collaborative group that did similar work. Theirs was a little different, and again, this is just an example from their paper. They did a series of improvement changes very similar to what the group in Massachusetts did, and they started by looking at prenatal education, staff education. Then they saw some improvements. They modified the Finnegan interpretation. Then they looked at treating methadone, how they treated their patients medically. And then in the end, they did the Eat, Sleep, Console tool, which again is a different way of assessing babies. And essentially, you see a similar response. You see a overall decrease in length of stay, and then you can see the various interventions that were tried. And then again, the percentage of infants that were pharmacologically treated. So what I think we learned from those two studies is that, again, by focusing on non-pharmacologic care, partnering better with families, changing the environment where these babies are cared for, we really can significantly decrease the need for pharmacologic care of the infant. And again, I should emphasize a couple things. Most of this work and the work that I'm going to present at CHoSEN really does focus on care during the birth hospitalization. There was some I think effort and impact with prenatal counseling and engaging families, but most of it, again, was within the hospital setting. And then I will come back to Eat, Sleep, Console when we talk about that at the end. These are a couple of just other interesting, unique examples throughout the country looking at the care of substance-exposed newborns. This is an organization based in Ohio called Bridget's Path, and this is actually quite unique. It essentially was created to provide medical care for babies with neonatal absence syndrome or withdrawal symptoms from opiate exposure in a home environment with their mothers. So essentially, the mother and baby go from are cared for in this institution. They provide their medical care as well as any additional care that's needed. So I think this, again, although on a small scale, is really an example of what might be possible. This, to me, is truly integrated care and keeping mom and baby together until not only baby is medically ready to go home, but that mom, from a social standpoint, is also that they're able to be discharged together. And then this is the maternal opiate misuse model. Again, some of you guys in the audience are probably more familiar with this than I am. But this, again, is another effort where beginning in the state of Colorado and other states throughout the country to really looking at trying to integrate care. So again, how to integrate care both prenatally, so co-location of care with mothers' prenatal care, opiate use disorder treatment, and then behavioral health, and then extending after labor and delivery, how you can co-locate and coordinate that care after discharge from the birth hospitalization. So then changing focus a little bit to pharmacologic care. So again, we talked a little bit about how we're trying to alter our mindset about how caring for these babies, but also looking at pharmacologic care. And just a step back for those of you guys who are not directly involved in healthcare, essentially the approach to pharmacologic treatment was you have a baby who is exposed to opiates throughout pregnancy, and then that baby is delivered and they no longer have that exposure to opiates, and they suffer withdrawal symptoms that are similar and can be clearly classified and identified. And so the approach was to, once the baby began identifying symptoms, we would start treating the baby with either methadone or morphine, and then gradually over time decrease their exposure to prevent withdrawal symptoms. So this created something that commonly looked something like this. This is just a typical graph of what you might see. So the initial line, that light blue green line, are the infant's symptoms. So infants would begin to show symptoms of abstinence or opiate withdrawal, usually within 24 to 72 hours of birth, and then they would peak. And then, so what we would do is once they began showing signs of withdrawal, we would begin therapy with either methadone or morphine with opiate replacement therapy. And then we would then spend a significant amount of time over the course of the baby's remainder of the hospital stay, gradually decreasing their narcotic or opiate dose, so to avoid withdrawal. And then people started thinking, well, maybe that's not the most appropriate way to do this, because you're really just prolonging the infant's overall exposure to opiates. So another approach was taken, which is what we've adopted through the CHoSEN collaborative, which is using medicines on a PRN or as needed basis. So rather than when the baby initially presents symptoms, starting a standard dose, a scheduled dose of either morphine or methadone, we would do PRN dosing. So essentially just providing the baby the symptom relief that they required at the time. And so that allowed us to have a much shorter exposure to opiates in the infant and lower doses. And then you can see a quicker wean for the infant, which would decrease length of stay. So then with that kind of brief overview, I just want to talk a little bit about what we've been doing in the CHoSEN collaborative. So again, we started, and this was referenced in the previous talk, we started just looking at variability amongst hospitals. So a group of us got together looking at the papers by Grossman and Alicia Walkman and thought maybe we can do better. There was a lot of overall, I think, displeasure with the care of these babies just from a purely medical and healthcare system. As far as the Finnegan system, the scoring system was complicated. It seemed very arbitrary. We had very prolonged length of stay for these babies who were in the hospital for weeks as they were weaning off of their methadone or morphine. And then most importantly, I think people had the sense that this really was not the best way to care for these babies. Again, putting them in a NICU, separating them from their families really was counterproductive. And we also looked at variability. So there was significant variability among hospitals throughout the state of Colorado, really looking at all aspects of care. So just some examples, maternal and infant drug screening, we just referenced to the previous question, was highly variable throughout hospitals. It still is, to be honest, although we are trying to at least come to some consensus, but that varies significantly. Infant assessment for withdrawal varied. Even though most hospitals were using the Finnegan scoring system, how it was done, when it was done, what babies were eligible for assessment was variable as well. Location of care for opiate-exposed newborns varied also. Some were cared for in the well baby nursery, but if they needed pharmacologic therapy, they were transferred to the NICU. Some hospitals, they were transferred to a pediatric inpatient floor, and there was a lot of diversity there. Degree of engagement of mothers also varied significantly. Some hospitals had an environment, plans in place where the mother could stay the entire hospitalization with the baby. So if the mom was medically ready to be discharged, usually within a couple of days, but the baby needed to remain hospitalized for medical management of their withdrawal symptoms. Some hospitals had the ability for that mom to room in and stay with her baby the entire time. Most hospitals did not, honestly. Again, when that mom was discharged, the baby was transferred to a NICU or was put in the kind of well baby nursery for boarding, and there wasn't a great opportunity for moms to be with their babies. And then pharmacologic treatment varied throughout hospitals as far as what medication was used, whether it be morphine or methadone, doses, all across the spectrum as far as pharmacologic therapy. And then criteria for discharge varied a lot also. So specifically whether or not babies could be discharged home on methadone therapy to be managed by a private or primary pediatrician or primary care provider. That varied dramatically, even within the Denver metro area. There were some hospitals who would routinely discharge patients on methadone, other hospitals that would, quote, never discharge a baby on methadone. And then there on and on and on. There's many different examples. As far as referral rates for early intervention services, other services, physical, occupational therapy, that also was highly variable across hospitals. So then this was the goal of CHoSEN Quick, as you can see there. We focused on developing a collaborative quality improvement initiative that was structured with quality improvement methods and sharing of data and practices. And that's how we started early on, was a clear understanding with the hospitals that were participating that they would openly share practices and also openly share data, because we really felt it was important to know what we're doing, to A, figure out what our baseline is, and C, are we actually making tangible improvements? And so we felt that data sharing was a key component to this. And then again, to have measurable improvements. So this is our driver diagram. It's been modified slightly over time, but this was our initial driver diagram. And again, I don't think we need to go through it in significant detail, but I just want to point out, again, sort of the complexity, and it was all encompassing. So even though our primary focus was on the birth, hospitalization, and medical management, we really wanted to incorporate both prior to hospitalization and then at discharge. So along the top in yellow, you can see that essentially is just looking at increasing hospital involvement. In the green is actually looking at postnatal exposure to opiates. So that was our mainstay, which was looking at medical management. We also, however, incorporated improved family involvement, and we'll talk about that with prenatal counseling, so trying to identify mothers prior to the birth hospitalization, and then create a process where we could offer prenatal education and counseling for those families so they knew what to expect, and also how to empower them to care for their newborns. And then lastly, we also looked at safe discharge and transition of care. So the first thing we looked at was Finnegan to Eat, Sleep, Console, and I referenced this earlier. So the Finnegan was the old assessment tool, and then we transitioned to Eat, Sleep, Console. And this was, again, to simplify the assessment of these babies and really focus on more physiologic and functional measures. I would like to say, though, that Eat, Sleep, Console is not considered standard of care. There have been no large comparison trials looking at Eat, Sleep, Console versus Finnegan, the traditional way we had done this, although there is interest in that, and I believe NIH is actually looking at creating a multi-center trial to actually compare the two. But just keep that in mind as I talk about some of our data. So now I want to go through and just talk specifically about what babies we're seeing in the collaborative and trends that we're seeing here throughout the state of Colorado. So this is data from, we began in 2017. We started collecting data the summer of 2017, and then this goes up through September of 2019, so the last quarter of last year. And you'll see changes over time. This is just some demographic data. So when this slide was created, we had 650 newborns actually had data entered into into the system. This encompasses all our hospitals. There's about now 20 different hospitals throughout the state of Colorado, and it represents about half of the births within the state of Colorado. So just to give you a reference point. So of those numbers, we had 650 newborns, and then you can see this is just a a breakup as far as maternal insurance, race, and ethnicity. So so the majority of our newborns had either public or Medicaid insurance, and then the maternal race and ethnicity, I think, really just reflects the state in general. So the majority were white or Caucasian. There's a large percent in gray that were unknown, and that has been a challenge with our data collection that we're working on. And then you can see the ethnicity there, the breakup between Hispanic and non-Hispanic. And this is based on mother, essentially, maternal identification of race and ethnicity. So this is some of our initial outcome looking at length of stay. So when we started in 2017, this is an average length of stay was about 17 days for all babies who had been opiate exposed. Now, some of those babies had no symptoms and went home within 2 to 3 days. Some of those babies required treatment and stayed for a prolonged period of time. And this baseline rate of about 17 days is similar to what you see in other parts of the country, or about 2 to 2.5 weeks. And then over the course of time, so along the bottom axis, so we started April, June of 2017 and goes through till July, September of 2019, and you can see a steady decrease in length of stay. Those babies that required pharmacologic treatment, we then took those patients out. So babies, again, that actually required medical management, the length of stay started at 25 days and went down to about 13 days. So I think even babies who were requiring therapy, we were actually able to decrease their length of stay to about half. This is another slide that just talks a little bit about some of the variation and how that changed over time. So this slide, the top line is the maximum length of stay. So again, in that quarter of data, the purple bluish line on the bottom is the minimum length of stay, and then the median is in green. And you can see when we started, there was huge variation. So you had anywhere from over 60 days, down to about 12 days, and then over the course of time, by standardizing and hopefully improving our approaches, you see a decrease in variation. So the lines actually converge, so that our last quarter, the difference between the lowest and highest length of stay was between 7 and 25. So then we look specifically at what number of our babies are actually requiring pharmacologic treatment over time. And again, this was primarily because of an emphasis on non-pharmacologic care. So our previous method was to assess a baby, and if a baby was showing signs of withdrawal above an arbitrary cutoff, we would begin medication right away, whether it be morphine or methadone. However, part of the CHoSEN collaborative work was really to emphasize non-pharmacologic care, and particular the role of parents and mothers in providing that care. So now what's done is the baby is assessed, and if the baby has concerns based on the Eat, Sleep, Console assessment, then they will there's a team huddle, and essentially that's where the nurse meets with the family and possibly the providers to talk about what's going on with the baby, how can we optimize non-pharmacologic care and keep this baby with its family and prevent needing to use medication. And so that has shown a significant reduction in the need for pharmacologic treatment, because a lot of times, especially babies with minor symptoms, simply just reinforcing non-pharmacologic care, altering the environment, improving breastfeeding, non-nutritive sucking, swaddling, skin to skin. There's a number of things you can do to really help those babies manage these symptoms without needing medication. And so that's just what we're seeing here, a nice decrease in pharmacologic treatment over time. So then that's the medical management. Then we wanted to look at breast milk, and this has actually been a challenge. Another significant variation, which still exists now, even with our CHoSEN work, and I'll show you some of that, is looking at breastfeeding management. So what women are considered eligible to breastfeed, what support is offered at the hospital level for breastfeeding, what support is offered after hospitalization for those mothers who choose to breastfeed. So these two slides, the first slide on the top is percent of newborns eligible to receive mother's own milk. So this is based on the hospital-specific guideline, if they felt that that was appropriate for that baby to receive mother's milk. And you can see that is pretty steady throughout the course of the collaborative, about 40%. Even though the guidelines are slightly different between hospitals, overall it's about 40% of these infants were eligible to receive mom's milk. Now what's interesting, out of those who were able to receive mother's milk, the percentage that actually were doing so is about 80% and has been pretty steady over time, frankly, over the course of the collaborative. So we started about in the 80% range and really has not quite reached 90%. So this is a main emphasis of our work, is for those babies who are eligible to receive mom's milk, how can we improve that process? Now this is by hospital, these are hospital-specific differences. So just along the bottom, you see each hospital is de-identified by a particular letter. And this is the variation at discharge. And again, this is for babies who were considered eligible to receive mother's own milk. What percentage were receiving mother's milk and formula, and then formula alone. And I think just the specific numbers are probably not important. What I think is more important is the variability. So it goes from 100% were receiving breast milk, and then, to somewhere, sorry, it's hard for me to see these slides up there, a significantly lower percentage. So then we wanted to look at antenatal counseling. So again, one of the things we talked about is looking at both before and after hospitalization. And as you'll see in the next series of slides, this continues to be a challenge. So I think we've done a lot of work in improving our in-hospital care, but really trying to reach families and mothers prior to birth hospitalization and after continues to be a challenge. So this looks at the percentage of women who received antenatal counseling, and this can be broadly defined. So whether that's from their obstetrician, their prenatal provider, whether that's an actual formal consult with a neonatal nurse practitioner or a neonatologist or a pediatrician, really anything across the board would count. And as you can see, we're really struggling still with this. So we started at well under 10%. And most recently are now just at 10%. We had a little bit of a peak sort of a year ago, but even our best was still less than 20%. So then I'll talk a little bit about at the end of what our current focus is, but this is definitely an area that still needs improvement. And then again, this just shows the variation between hospitals. So highly variable, as well as which women got counseling, which did not, and then how well we can even assess that. So the gray bars is where it's simply unknown. And then discharge. So looking at discharge disposition of our opiate-exposed newborns. So this is just sort of some general information of the whole cohort. The top pie chart shows where those babies were discharged home to. So home with their biological parents was still the majority at about 2/3, and then another significant portion in dark blue were discharged home either to foster care or guardian care. We also looked at early intervention referral as sort of a marker of access to services as an outpatient for ongoing developmental therapy and intervention. And you can see that there is a still significant percentage of our babies, about half, are not receiving early intervention referrals. And then the last thing we looked at was actually handoff to a physician, so meaning a verbal handoff from the treating provider in the hospital to the primary care provider. There's a big concern, which I think is relevant and something we're still addressing, is to whether or not we're just shifting the burden of care from the inpatient setting to the outpatient setting. So if we're discharging babies earlier, there's, I think, a significant concern that the primary care pediatrician, the family practice physician, are going to be the ones who are, taking, assuming that care. And so we wanted to track and make sure we were getting proper handoff from one facility to the outpatient center. So we're showing a little improvement with early intervention. So this is, again, one of the easiest things for us to control. These are referrals that are made in the hospital setting prior to discharge, and we have seen a nice increase, I think, in early intervention referral. Part of this may vary a little bit on the hospital. So initially, when we first started, there was a lot of variety in what infants were even considered eligible for early intervention and how that process was done. So we're trying to standardize that and seeing some improvement. And then handoff to the primary care provider, again, continues to be a struggle. So you can just see over time we haven't made a significant improvement, and still less than 30% of our patients are being discharged with an actual verbal handoff. So then next steps. Again, that's sort of a summary of what's happened over the last 2 years with this work. Now we're trying to focus specifically on some of these areas that we think we need to target. And we've decided to do this by targeted effort at local hospitals rather than looking at the collaborative overall. So first we are doing prenatal counseling. So looking specifically at Parkview Medical Center to look for how we can improve our prenatal counseling. We have created educational videos that can be offered to families to see if that would improve access, since there are significant barriers to access for care. And then we're also looking at whether or not those videos lead to increase actual face-to-face consultation, and also what experiences those families have. So whether they feel the video education or the face-to-face consultation is helpful in managing their expectations and preparing them for the infant's hospitalization. The next thing, we're looking at breastfeeding. So again, you saw our breastfeeding data, how to improve breastfeeding rates for those infants who are eligible for maternal milk. And we are focusing with the hospitals at the lowest breastfeeding rates to see what some of the barriers and opportunities are there. Safe discharge, I'm going to leave that for the rest of the meeting. But essentially, we are Annie Hall, who is at a Poudre Valley hospital and one of our steering committees, as well as the group from Poudre Valley, has done a lot of work in creating the safe discharge checklist, and a lot of work figuring out how we can implement that well in the hospital setting, and then hopefully be able to identify best practices and then incorporate that to the rest of the collaborative. And then parent engagement and parent experience. So we now, I think, are at the point that we would like to hear directly from families. So we've done a series of qualitative interviews with families to get a sense of what their experience has been in the hospital. And then we also are doing qualitative interviews with staff as well. So whether or not this, there's a number of changes that have been implemented, what does staff feel about these interventions? And then lastly, the group we have not quite been able to target, but the next group we want to target is primary care pediatricians. Again, we want to get a sense of when these babies are being discharged from the hospital, how is that transition going for the family and the pediatrician? Does the pediatrician or primary care physician feel that they have the resources that they need? And again, to make sure that we're not simply shifting the burden from the inpatient setting to the outpatient setting. And then lastly, our goal is always to increase hospital participation. So as I mentioned, we now have 2 hospitals in Wyoming which have joined the collaborative, and so we're working with them to really, I think, create a regionalized collaborative that just doesn't focus on the state of Colorado. And again, that obviously brings its own challenges, because the state of Wyoming and the state of Colorado are very different as far as legislation, and as well as hospitals or services available both before and after the birth hospitalization. So there's just acknowledgements. Again, this is a tremendous amount of work that's been done over the last 2 years, and we just want to acknowledge everybody who's been influential in that. So Randy Wilkening is the section head of the Colorado School of Medicine Neonatology Department, and actually he was the one who sort of brought a small group of us together with some of these newer articles from the East Coast and said, what do you guys think about this? Do you think we could do a better job? And he's been very instrumental in offering us support. And then again, partnering with Illuminate Colorado and CPQCC has been very instrumental, especially, Illuminate has been fantastic to work with, and I think we've really seen development and growth of this work that would not be possible without those partnerships. And then the steering committee is listed there, and then as well our funding agencies that have given us significant support. And then lastly, these are the hospitals. Again, just to thank the hospitals, some of which I know are represented here. I recognize some people. And again, just as an acknowledgement and thank you to the individual work that you guys are doing at each hospital. And I think we are seeing some initial, I think, promising improvements, but still, lots of work to do in the future. And so we continue to want to be able to partner with you guys. So, all right. Thank you.